Good morning again. And thank you again for the invitation, Professor Gadano. So go. So my name is Richard Morreau, coming from France. And you know, some years ago, intuitively, we thought that a syndrome characterized by the existence of multi-organ failures was a final common pathway driving death in these patients. And this syndrome was called by Sir Roger Williams and Rajiv Jalan acute and chronic liver failure, ACLF. But we know that its components were very poorly identified. This is why in Europe, under the leadership of Vicente Arroyo, a consortium called EASL-CLIF Consortium was created in 2009 in order to address the major questions raised in terms of research in the field of cirrhosis. And when we met for the first time in Barcelona in July 2009, the steering committee decided to obtain an evidence-based definition of ACLF via a European prospective observational agnostic, it is a very important study in a large number of patients. This study was called Canonic and was designed using very important assumptions. First, patients should be admitted to the hospital because of an acute decompensation of cirrhosis. Second, we decided to use a modified SOFA scale to diagnose the existence of organ failure. And also we decided that 28-day mortality rate should be at least of 15% or more to be associated with ACLF. These were the three most important pre-specified criteria. A few words on the SOFA scale, which was named CLIF SOFA scale. It takes into account 6 organ systems: liver, kidney, cerebral, coagulation, circulation, and lungs. And each organ system received a score ranging from 0 normal to 4 most abnormal. In yellow, I show you the definition used for organ failure: bilirubin of 12 or more for liver failure, creatinine of 2 or more for kidney failure, cerebral failure defined by a grade, West Haven grade of 3 or 4, coagulation failure defined by INR above 2.5 or platelet of 20 or less, circulatory failure defined by the use of vasopressors, and lung failure defined by a ratio of PaO2 to FiO2 if available, or SpO2 to FiO2 if you have the device for measuring SpO2. Okay, so this was the minimum information we had before starting the study. Let's see the results. You know, this is the main result of the Canonic study, which is a definition of, I would say, traditional AD and ACLF. The first result, as you can see, the first line, patients who didn't have organ failure were considered as having traditional AD because the mortality rate was very low, less than 5%. If you see patients with single kidney failure, they had the mortality of 22%, and we considered that this patient had ACLF1. But we were very surprised to see that you know, the difference between patients having ACLF1 or not having ACLF1 was a little bit surprising. For example, if you look at patients with a single organ failure, liver, coagulation, circulation, lungs, but almost normal kidney function and no hepatic encephalopathy, the mortality was very low. Therefore, we consider that they had no ACLF, they had traditional AD. The same for patients with single cerebral failure and almost normal kidney function. They had a very low mortality rate. In contrast, if you look at patients who had a single organ failure, liver, coagulation, circulation, lungs, and kidney dysfunction and or mild to moderate hepatic encephalopathy, these patients had at least 20% mortality rate. Therefore, they have ACLF1. And finally, patients with single cerebral failure and kidney dysfunction also had a mortality rate of 20% or more, and therefore we decided to classify this patient among ACLF1. And finally, it was easier for patients with 2 organ failure, ACLF2, and 3 organ failure or more, ACLF3, because mortality is rising across these grades. I must say that this classification is very important for a clinical point of view because, as you know, you are aware of the paper published by the Barcelona group showing that if you look at patients with type 1 hepatorenal syndrome at enrollment before telepressin, you must predict that patients would have a high Cliff-SOFA score will not respond to telepressin. This is an example. Yes, knowing that what is ACLF, we were able to describe the clinical phenotype of patients with ACLF. And one interesting result and surprising result for us, because we were expecting that patients with ACLF were at the end stage of the trajectory, you know. And this was not the case, because when we looked at the previous history of decompensation, it was absent in 20% of patients, or very recent in 20% of patients. Therefore, ACLF can develop very early in the history of cirrhosis decompensation. It was a first information important to me. We also discovered that patients with ACLF were younger. There were no gender issue. Male and female are equal in terms of risk of ACLF. Patients with alcoholic cirrhosis were more prone to develop ACLF, and patients with ACV-related cirrhosis were less prone to develop ACLF. Why? I don't know. It is a matter of research. Why patients with HCV are relatively protected as compared to alcoholics. An important point was the trigger. As you can see, the prevalence of bacterial infection was higher in patients with ACLF than in patients with traditional AD. Therefore, patients with bacterial infection plus ACLF are those patients who have severe sepsis or septic shock. Septic shock or severe sepsis is a form of ACLF for us. The second trigger, very important trigger, was active alcoholism during the past 3 months. It was more prevalent among patients with ACLF. The prevalence of gastrointestinal hemorrhage was less important in patients with ACLF, and probably because the management of patients with GI hemorrhage is very well standardized. And Another surprise in the study was that almost 40% of patients with CLF came to the hospital without any identifiable trigger. And this is also a matter of research. Why do these patients develop a CLF? Is it due to bacterial translocation or translocation of pumps? We don't know. A final result was very important. We discovered that ACLF was associated with systemic inflammation indicated by leukocyte count and C-reactive protein levels in the blood. And as you can see, these markers increase across ACLF grade. But also I would like to draw your attention that patients who didn't have ACLF had a high level of CRP. Therefore, probably cirrhosis, even if it is not complicated by ACLF, is associated with subclinical systemic inflammation. So in sum, we have a population of patients who are non-electively hospitalized for an acute decompensation, meaning pneumocystis, encephalopathy, infection, hemorrhage, or any combination of these. 70% of these patients have traditional AD, which is characterized by low-grade systemic inflammation, no organ failure, in hospital mortality of less than 5%, and 30% of patients have ACLF, characterized by high-grade systemic inflammation, organ failures, and high in-hospital mortality. The clinical course is interesting also. This has been studied very closely by Thierry Gusteau, who is based in Brussels, and he looked at the canonic series. On the left column, you have the initial grade of ACLF, 1, 2, 3, and in the other columns, you have the grade of ACLF between day 3 and day 7. In red, you have the patients who didn't change their ACLF grade, and as you can see, 25% of patients with ACLF1 remain ACLF1, 25% of ACLF2 remain ACLF2, and 70% of ACLF3 remain ACLF3. And also, you can see that ACLF is a very dynamic syndrome because some patients with ACLF1 or 2 worsen to ACLF2 or 3, but also patients with ACLF1, 2, or 3 initially improved. Even patients with ACLF3, 16% of ACLF3 were without ACLF criteria at day 3 to 7. Therefore, day 3 to 7 is a very good time to assess the severity of these patients, and therefore initially these patients should receive a maximum of intensive care. Okay? And this classification translates into probability of transplant-free survival. As you can see, patients without ACLF on day 3 to 7 have a very good 3 months and 6 months survival. In contrast, patients with day 3 to 7 ACLF3 had a very poor survival. And this raises a very important question. Do we transplant these patients, ACLF2 or 3? This is a post-hoc analysis of the canonic that Thierry Gusteau did, and it is he looked at patients with ACLF2 or 3 who did not receive liver transplant as compared to patients who received liver transplant. And as you can see, patients who receive liver transplant had a very good prognosis. The survival at 6 months was 81% as compared to 10%. Okay, so these results are very encouraging, but we have to refine the indication for liver transplantation in this patient. This is another analysis from canonic that Thierry Gusteau did. On the left column, you can see the number of organ failure at day 3 to 7, 0, 1, 2, 3, 4, 5, etc. And the 28-day mortality and 88-day mortality in these patients. And as you can see, when patients have initially 4, 5, or 6 organ failure, the mortality is extremely high, 100% at 28 days. Therefore, what should we do for these patients? I would be in favor of giving them a liver transplant, but this should be discussed. Assessing prognosis now. This is a collateral benefit of Canonic. We simplified the EASL-CLIF SOFA score, and we now use a CLIF C organ failure scale, which is based on always on 6 organ system, but using only 3 subscores, okay? And in the gray zone is a definition of organ failure, which is exactly the same as in the CLIF SOFA score. Okay, this was one of the benefits. Another benefit was to design new prognostic score, which are very useful, at least in our experience. In 2014, Rajiv Jalan described a score called CLIF C ACLF score, which was based on CLIF C OF score, age, and leukocyte count. Jalan also published the CLIF C AD score for patients with acute decompensation and to make the prognosis of these patients. And this score uses age, creatinine, leukocytes, and sodium, and INR. It is a modification of MED, in fact, but it is very useful because it takes into account leukocytes, and as you know, we think that leukocytes are a very important marker for the severity of patients. Okay, so in conclusion, I think that ACLF is a distinct syndrome which is distinct from traditional AD, based not only on the presence of organ failures and high mortality rate, but also on age, type of triggers, and the presence of systemic inflammation. Bacterial infection or excessive alcohol consumption are common triggers of ACLF. However, 50% of patients do not exhibit any trigger for inflammation and ACLF in these patients. The finding that liver transplantation has been used with success in patients with severe or very severe form of ACLF needs to be confirmed. And I must say that I'm talking about the European experience. I hope that somebody in Latin America will soon be able to talk about your experience of ACLF in Latin America, because ACLARA study will be launched very soon. And I can tell you that in China, they submitted a paper very recently describing HBV-related ACLF, showing that there are some difference between the Chinese patients and the European patients. But, you know, this is a very well-established syndrome. Therefore, I would like to thank you for your attention, and I'm ready to answer the question.